Hi, my name is Stan Conti, and this is episode 8, Concussions, NHL, NFL, MLB perspective on concussions. First, just a couple words. Nancy Flynn and I'd like to welcome all back to our sports medicine conferences. Some of you guys are new, others are returning. As many of you know, we have done 7 episodes in 7 weeks during April, and all of us needed a break. No one more than me. But now we're back, we're re-energized and ready to continue. We started these webinars when pro baseball spring training shut down, and we thought it would be good to have the medical staffs get some continuing education while they were sitting around the house waiting for it to reopen. Initially, it was only MLB medical staffs, but then we decided to open up the invitations to the colleges and high schools because we're seeing those people starting to lose their jobs as the schools' athletic departments shut down. So we invited them, and we kind of grew as we went along. So as the COVID pandemic continues, we saw a need to continue to offer CEUs, free CEUs for quality educational programs, which we think we're providing. We see by the registration numbers, you feel the same. We have over 1,000 people attending this webinar. Although we've concentrated on baseball in the past, we're now expanding to other sports, as you see in episode 8, because we're bringing in the NHL and the NFL in. And we know everyone in this room, this virtual room, have been educated on concussions. But this episode is more designed to show some of the similarities and the differences on how the MLB, NHL, and NFL handle the concussions. We'll be hearing from the guidelines and protocols from each sport and how the sport handles issues specific to their particular sport. Just some rules what we're going through here so you know where things are happening here. Each speaker will give their talk, and after all 3 are completed, we'll have a Q&A session after that. Please submit your questions to the Q&A button, not the chat button, the Q&A button. And you can do that anytime during any of the presentations. Nancy Flynn will be looking at those and selecting those out so we can present your questions to the presenters during the Q&A sessions. We've invited 3 great speakers here on the topic. All are not only frontline people, but they're on the sidelines of their sport. We want to get their perspective in regards to how they see their jobs, what is important to them, how they do it on a real-time basis. What do they do in the locker rooms? What do they do to take them on? What's return to play during the game? And also the specifics of their sport. We just put a poll up that we'd like you to take. This is some of the things we do before. Just to get some idea of what people think in the audience. There's no right or wrong answers. In a little bit in between speakers, we'll give you the results of this. But some of the things that we're asking you'll hopefully get from the speakers in regards to answers. But it's nice to kind of see from straight out of the gate what people think. So that'll be on for a little bit. Now, I'm gonna.
Dr. Batten is ready.
Okay. Oh, okay, great. All right. Gotcha. We're having a little timing. We have quite a bit of timing issues now that everyone's back at work, and especially the pro doctors and athletic trainers. They're working pretty hard in trying to get their sports ready to go or in the middle of doing it. So, so here's our 3 speakers. Casey Batten, who's the Los Angeles Rams team physician. Kevin Morley, athletic trainer and head trainer for the New Jersey Devils, and Gary Green, who's the Major League Baseball medical director for all of Major League Baseball. Before we get into the speakers, I want to thank our speakers that we just introduced for donating their time. These people donate their time and expertise to make this webinar possible. It also decreases our costs, so we can keep giving the CEUs for free. In regards to the CEUs, you can see it's important to be able to do the survey that will pop up at the end of the Zoom. You'll also get an email 24 hours after the presentation to do the survey again. Really important, especially for the athletic trainers, to do that survey because the BOC requires that. We are working very, very hard to start going with EBP CEUs, which you know are hard to get. We've pretty much have submitted one. It takes about 8 weeks to get approval. We're hoping the rest of the ones that we start doing, you'll get EBPs and not just category A's. The video on this episode will be uploaded to contiperformance.com to view, and it's at no cost, so you can do that. Certificates will be mailed out the next week. Nancy Flynn is in charge of that. You can write down her email there, but we'll be sending you information as well. So our first speaker is Casey Batten. He's a primary care sports medicine physician, director of primary care sports medicine, and he's the director of Curlin Joe Primary Care Sports Medicine Fellowships. His education is University of Wisconsin-Madison, Bachelor in Science and Kinesiology and Exercise Science. Did his medical degree at College of Wisconsin. He did his residency at University of Tennessee, and also did his fellowship at UC Davis and UC Berkeley sports medicine fellowships in the Bay Area. He has been the team physician for the University of Tennessee Chattanooga from 2003 to 2005, and then Cal football from 2006 to 2016, and has been with the Rams since 2016. So we've got somebody who's got a lot of football experience and sideline experience. He was the head team physician at the University of California, Berkeley for 6 years. Prior to that, he served as the assistant clinical professor at University of California, San Francisco. Widely published, respected teacher in sports medicine, has presentations at the NFL Physician Society, PBATS in the baseball sector, and the American Medical Society for Sports Medicine and the American College of Sports Medicine. Okay. Casey, you're on.
All right, can you hear me all right?
Yes.
All right, how's that look?
Perfect.
All right, well, hey, thank you to Stan for the intro and inviting me to speak. I'm excited to hear Gary speak and Kevin speak. This is really kind of a great opportunity for me to listen to other people in the other leagues talk about their experiences. And so my goal here is to sort of just give you a flavor of how we do it in the NFL. I'm not going to go into a lot of the nuts and bolts on how you manage concussion. I'm sure a lot of you guys are experts at that. I'm just going to try to hit the highlights of how we do it in the NFL and maybe give you a little look behind the scenes. And so this should be hopefully helpful for you guys. All right, let's see here. All right, nothing disclosed related to this lecture. Concussion stats. I like to talk a little bit to sort of set the table on sort of how many concussions do we see in the NFL. This is over the last, well, basically from 2012 to 2018. I didn't have a slide with last year's numbers in terms of just number of concussions that fits on this slide. I have one a little bit later. But really what they were looking at is from 2012 to 2018, preseason, regular season, both practice games, you know, what was the actual number, total number of concussions that we were seeing. And actually, as we moved along, we were actually seeing at the end of 2018 a sizable decrease in the actual number of concussions. But we talk about this all the time in our committee work is, you know, football's a contact sport and we're never going to get this number to zero. And so the hope is as we continue to refine our research and our rule changes and our coaching and our detection methods and treatment methods, that at some point this number will level off. And at some point, you know, in theory, we're going to reach, you know, what the normal number of concussions are going to be, realizing it's never going to be zero. So until we see this level off over several years, obviously we need to put a lot of time and resources into this until we feel like we've hit sort of the rock bottom. And for the most part, you're looking at back in 2012, 265 injuries down to 217 in 2018. There we go. So that's the number of concussions. You know, how are people sustaining concussions? This is looking at tackles. That's not just, this is the person doing the tackling and the person being tackled. So that's tackling and tackled, blocking, blocked, diving, leaping, other. the vast majority of these are during the tackle, whether you're the one giving the tackle or the one receiving the tackle. And so we focus a lot of our time and energy looking at that particular situation. This is last year's data compared to 2017, 2018. UNC stands for Unaffiliated Neurotrauma Consultant. I'll talk to you about that position, what that physician does in their role here in a little bit. But this is the outcomes of these evaluations. So if you combine the preseason and regular season games in 2019, we had 485 evaluations completed. Okay. So this first one is those who were removed from play and did not return back to the football field. So here you're looking at 100. Can you see my arrow? I don't know if you can, but 106 people were removed from play out of those 375 evals in a regular season. And I'll talk a little bit later. Ultimately, 10 of these people were not even diagnosed with concussion. So that does show that, we at times have been more conservative on iffy cases, and we're not pushing everybody else back onto the field. If you look at those who were allowed to return to play between preseason and regular season, we did have about 8 people who were returned to play, everything checked out, but perhaps post-game or usually the next morning, they had symptoms that were suggestive of a concussion, and the diagnosis was flipped to a concussion. So, at the end of the day, less than 3% of all evaluated players are ultimately returned back to play after eventually being treated for a concussion. So that's about 8 cases a year that we'd like to avoid. But as you guys know who have sideline experience, these injuries, like we say, bloom, and they're not always evident. And no matter how expert you are, no matter how many tests and tools you have available to you, no matter how well you know that player, we're not going to be perfect. But we're doing pretty well, I think, based on these numbers. So concussion management, like I said, I'm not going to go into all the nuts and bolts. I'm fairly certain the NHL, Major League Baseball, and I know the NBA, all for the most part, follows the same type of guidelines. I'm going to break this down to a little bit of sort of baseline preseason work, risk assessment. I'm going to dive into the protocol itself, and then I have one slide on sort of the return to play paradigm from the NFL. So obviously, any talk on head injury, spine injury, heat illness, et cetera, begins with an emergency action plan. I talk to a lot of high schools and small schools and can't emphasize this enough on how important an emergency action plan is. Some people may not think a concussion in and of itself is a catastrophic injury, but you never know if they have a concomitant spine injury or there's something else more nefarious going on like a bleed. Luckily in football, that's exceedingly rare. Not only do you have to have a written action plan, you need to rehearse this with everybody who's involved. And for us in the NFL, this is one thing that we've done, and it's going to probably move to being mandatory. We actually hire an outside company to come in and run through different scenarios. We go through the cardiac protocols. We go through C-spine protocols. We talk a little bit about concussion assessment. And this is all done by a third party. They videotape things. They give us different scenarios. They critique us. And then they write up the whole report and log that with the league to document that we did that training. And this has been really, really helpful for us. A lot of us have a lot of experience in this, but it's always good to talk to people who do this for a living. And maybe they have a new little tip, a new little trick, a new little tool. So we really like having these groups come in. Concussion baseline testing. Every player, every year, obviously starts with a basic history and physical. They get an update on their concussion history. Obviously, people could get concussions in training that we don't know about. So we want to know when we onboard them at physicals that they've had any previous injuries, not just from football. And then they get a good neurologic examination. In terms of baseline neuropsychological testing, that has to be done every 3 years, basically consists of a computerized test. We still use Impact. And then we use a version, basically the SCAT-5, and we're using a NFL version of the C3 logic system, which you guys may be aware of as well. We used to use X2, but they're no longer in business. If you have a head injury from the previous years, you will get a new neuropsych test baseline before you start contact and before camp. Baseline exams can be done with paper and pencil. I'll tell you, I have a great neuropsychologist that works with us. If I have somebody who has either a complicated history, maybe they have comorbidities, anxiety, depression, ADD, some of those people I may want to get some more formal baseline testing to document just to assist with any return to play decisions that may pop up during the season. All of these baseline tests are reviewed by myself and our neuropsychologist. If we deem any of these to be invalid, they're taken again under direct supervision. But for us, we pretty much directly supervise them anyway. This slide just shows you how many medical professionals are in a stadium on any given regular season game. Playoffs, sometimes they increase these numbers a little bit, but there are 30 game day medical staffs. We always joked it's probably the safest place to be in America. On top is what each team has unique to them. So there's 10 different providers, double that, that's 20. So there's 10 on each sideline. There's typically 4 athletic trainers, 2 sports medicine physicians or primary care doctors, 2 orthopedic surgeons, usually 1 chiropractor, and 1 unaffiliated neurotrauma consultant. Up in the stadium that are not necessarily dedicated to each team, but more for the field in general, you have 2 independent athletic trainer spotters that are up in the booth. Now, 1 spotter is designated to each team. We have an x-ray tech, an ophthalmologist, a dentist, EMS crews. We have an emergency department physician that manages an airway should that be needed. A VTML or visiting team medical liaison isn't really germane to this talk, but they help with prescription writing for the out-of-towners. And then we added a 3rd UNC recently to the booth. So unaffiliated neurotrauma consultant, people hear a lot about this. These people are unaffiliated, so they're not attached to a team. They are recruited and retained by the NFL. They typically are in one of a few specialties, either neurosurgery, neurology, or physical medicine and rehab. And, some people have tons of head injury management experience, some don't. But I have found in my experience, they've all been excellent to work with. And I know up front, me being only in the league going on 5 years, I know when I entered, there's some people who were been in the league on the sidelines for decades and were a little resistant to this program. Coming from the college ranks at Cal, where we didn't have this person, I'll explain later, but I've really enjoyed this program and really feel it's made my job easier, and I'll tell you why here in a bit. So we have a thing called the 60-minute meeting. So basically outside the locker rooms or in the referee locker room, the referee comes out, and it's basically the team physician from each club that does head injury management, the head team physician from each club, and then the ATC spotters, the UNCs, the UNC in the booth, usually a person from the NFL game day operations, and then your paramedics. We introduce ourselves to each other and to the referees, and we basically identify, who's doing what, who's communicating with who's dedicated to each team, and how we're going to communicate. And for the most part, this is all done, through headsets. One of the reasons why this ever came about is in the past, there were some issues with the referee not knowing who the medical staff was, and sometimes they would kick people off the field that they thought were coaches that were actual medical staff, or if they were personally removing a player from the field, they didn't know who the medical staff were, where they should actually bring them, and there's reports of referees bring them to coaches, and they maybe didn't get tended to as quickly as they would. So this has been a pretty brief meeting, but also very helpful. So you hear about the protocol all the time, and the protocol is that it's a protocol. It's a little bit of a cookbook medicine approach, but we really do sort of tailor this protocol, if you will, to each individual case. This is just a template. We just have to pass all of these steps, but the manner in which we do this, the speed in which we do this, completely is dependent on a case-by-case basis. So this slide just sort of sums up the protocol, and I'm going to kind of go through that step by step. But basically, after potential injuries identified, the team physician will evaluate this player either on the sideline or in the tent, and that they have to have their helmet taken away from them until we clear them to go back. Obviously, we've all had players that have tried to get back onto the field without being cleared, so taking their equipment has been helpful in mitigating that. The unaffiliated neurotrauma consultant participates in this evaluation. They usually see these guys with a red hat. They usually follow the team physician who is responsible for concussions on the field. They usually stay kind of hip to hip just for communication. So it's just easier. And they are present for any sort of evaluation that is done from a concussion standpoint. And the other thing that's interesting too is that if there's a suspected stinger, we're still having to do a full head injury evaluation, and the USC is involved with that as well in terms of supervision. So if after a short exam, we suspect there's a concussion, we have to go back into the locker room to do a more comprehensive eval. The UNC will accompany the team physician and the player to the locker room to conduct that as well. And if they're diagnosed, this is called the Madden rule. Basically, that player cannot come back out onto the field for the remainder of the game. They need to stay in the locker room with a member of the medical staff. That can be a team physician, it can be an athletic trainer, and they basically just need to be observed and serially examined to make sure they're not going south. And then typically at the end of the game, we do one final eval before we get on the bus if we're on the road and head to the plane. If for some reason the UNC or the team physician believes that a hospital visit is required, the UNC helps facilitate that as well. So identification of the injury, how do you sort of initiate the protocol? If a player exhibits or reports any signs or symptoms of a concussion on the field, they have to be immediately removed and evaluated. Case closed. That can come from a doctor, an athletic trainer, one of the ATC spotters, a UNC, a coach, a teammate, an official. If anybody initiates that protocol, regardless of what the player thinks, they have to be evaluated. Now, the extent of that eval, which I'll talk about in a second, is negotiable, but they have to be evaluated. It's not just a quick go up, say, hey, how you doing? They say, I'm fine, and you go back in. There is a process. And just so you know, I got the percentage, about 27% of all evaluations were from player report, self-report. No one else saw it. No one else was concerned. A player came up 27% of the time and initiated this protocol on their own, which I think is a fairly high percentage. So again, concussion protocol. You can get this from a teammate, whether it's on the field. Sometimes there's players on the sideline that had a better view. I've definitely had teammates say, hey, you better check out number 25. Coaches, I've had coaches speak up. Game officials have become much more involved in pulling people off. ATC spotters in the booth, the new UNC in the booth. And then again, the UNC from either side can initiate a protocol. And a couple years ago, they allowed any of these people, including the physicians, to call a medical timeout. So we do have the ability to stop a game if we think that a ref or someone else did not properly identify a potential injury. We can stop the game, get the player off safely, and do our evaluation. And I believe last year in the regular season, there was 19 medical timeouts. So it's not like it's very intrusive on the game. I think we do a pretty good job identifying these and not having to call the timeout. So this is just sort of a sideline setup. People talk about the blue tent, what happens in the mysterious blue tent, really nothing too mysterious. I'll go over what we do there. But if someone comes off and we're not totally convinced that they have a concussion, they don't have any of the no-go symptoms, oftentimes I will put players into the blue tent, and we do our brief assessment under with the UNC watching. And to be honest, the main job of the UNC is they basically have a tablet computer, and they're there to make sure we follow the protocol to a T. Every time we complete the step, they make a check mark, and then they report that back to the league. A lot of times I'm doing my initial eval in the blue tent. If I see a no-go symptom, or I'm very convinced just by watching the play and their response to the blow, you can bypass the tent and go straight to the locker room for the full evaluation. So you have some leeway here in where you do your eval. You just can't do it sitting there on the bench or in the view of others. It should be in the tent or in the locker room. And the tent's not meant to shield people from watching what you do. It's really kind of giving you some privacy, getting the player calmed down if they're antsy, which you guys know happens a lot, and allows you, even though it's thin material, for whatever reason, it does allow you to hear them a little bit better and get a good eval. And if it's a day game too, if you're doing a neuro exam, it's a little darker, use your flashlights, etc. So this is the most up-to-date version of the protocol. I'm just going to fly through this and then I'll be done. Hopefully I'm not going too long here. But the top yellow bar is how you initiate this. And the one thing I want to point out is that they have to have an impact to the head, and they have to have some sort of sign suggestive of a concussion or stinger, or the players report symptoms again, or someone else pulls the trigger. The key here is we had some trouble when we started this program, and when I was at Cal, we actually had ATC spotters as well, is we had a lot of calls down to the field from the spotters in the booth saying, hey, 25 had a really big hit, check them out. And that really was not a very good way of one, capturing injuries that led to a lot of useless evals, poor communication, and a lot of upset people. So if they're calling down, not only do they have to have a injury they think that could have caused a concussion, they have to have another reason. So it's a blow to the head or body or anything else that may be putting that player at risk, and something else for them to initiate the protocol. So it's really cut down on a lot of needless evals. So again, I already talked about this. This is walking through the protocol. So initiating it, obviously they should have some type of injury. Do they self-report? Do they show signs? Did someone else report concern? Then they have to be assessed immediately, whether in the blue tent or in the locker room. What is the go or no-go signs or symptoms? So if you have a no-go, any of these, and there's one more, regardless of what your evaluation is, this player cannot go back into the game that same day. Now, they don't always end up being diagnosed with a concussion, but it doesn't matter. So what are those? One, any loss of consciousness. Do they have an impact seizure or fencing posture? Do they have any type of amnesia or confusion? If they have any of those three things, they are done for the game, no questions asked. Those are the type of people I usually bypass the tent. I go straight into the locker room, do the eval, because we have to document it anyway. The other one is gross motor instability. They've refined this criteria over the last few years. It's not just somebody getting up and stumbling a little bit. We see that all the time. If someone has an ankle injury, maybe they got the wind knocked out of themselves. So there is some leeway in interpreting if it's true gross motor instability. And we can do that based on our assessment, looking at the video, but really in consultation with the UNC, if we think this is caused from a potential concussion, this is that player is designated a no-go and they're done for the day. So sideline survey, again, let's say I'm taking this person into the tent. What are we doing in that tent? Okay, so we take their helmet, we go in, try to get them to calm down. I typically will introduce the UNC, say, hey, this is Dr. So-and-so. They're going to watch me do this eval. And I go into doing a history of the event, trying to assess if they have any symptoms. Did I observe any signs? I ask them the Maddox question. You know, what stadium are we at? What quarter are we at? Who scored last? Who did we play last week? Did we win? Did we lose? And then I do my focused neurological exam, which basically is cervical spine injury, cranial nerves, coordination, and balance. All right. If you do this correctly and the player participates and it doesn't take you too long to calm them down, you can do this very rapidly. It does not take very long. Now, let's say everything looks good. I typically turn to my unaffiliated neurotrauma consultant and I say, hey, Dr. So-and-so, do you have any additional questions? Would you like to do any additional examination? Almost never do they have anything to add. They say, nope, I'm good. At this point, this is not necessarily part of the protocol, just my style, is we typically should agree that we're going to either return this person to play or we're going to take them back for more eval. Just to be cautious, just in case there's disagreement, I don't want to have a discussion in front of the player. So we like to do that outside of the tent. And I use the video review typically as my excuse to leave the tent together. So I say, hey, player X, Dr. So-and-so and I are going to go look at the video. We'll discuss your case. We'll be right back. So we look at the video. If we feel everything checks out and we're going to return them back to the play, we agree. We go back in. We deliver the news to the player. The UNC usually will communicate back up to the booth that this player is cleared. They're able to go back on the field, and we go from there. If we think they need more eval based on anything, typically I bring the UNC in there and we give them that news that we need to go to the locker room. So I already said, if the survey is normal, replay is benign, based on the video, we can send them back in. If we're unsure, or if we have any no-go symptoms, or we have any, findings on exam that's very consistent with concussion, they're going to the locker room. I may or may not review the video in real time. I may come back out and do it. I may be able to review it in the locker room. But just at some point, I do need to replay the video to document that in conjunction with the unaffiliated neurotrauma consultant. When you go into the locker room, now we're doing the full locker room comprehensive eval. We're using more or less the SCAT-5, which you guys are familiar with, and we do a very, very comprehensive neurological examination. Obviously, if there's any abnormalities, especially in the neuro exam, there could be a decision to go get further studies at the hospital. I can tell you in 5 years, I've never had to send somebody for any further evaluation in the NFL, and only a handful in college. So if the assessment is normal, again, we discussed the case with the UNC, and we can allow them to come back to play. That happens all the time. If not, then obviously they need to stay in the locker room like we discussed for regular follow-up and observation. This is one of the beauties of having the UNC program. And I'll just be honest, some players get really angry if they have minor symptoms, or they truly don't believe they're concussed, or maybe they're truly concussed and they're just emotional. And they tend to blame the UNC as working for the league and stopping them from playing. And a lot of times the UNC gets all the blame and we don't. And so it can be helpful for the doctor-player relationship. What's interesting, though, what they may or may not know is technically the UNC does not have the final authority for return to play. That really is a team physician's decision. You could, in theory, override if a UNC says, I think they're concussed, I don't want them to go back. In theory, you could override that, but obviously that would be a big problem, especially if anything ever went south. And so thankfully, I don't know of any cases that have really blown up and there's been disagreement. In terms of concussion follow-up, I'm not going to go through all the details. This is just the one slide I was talking about. But basically, whether you were diagnosed with a concussion or not, if you were evaluated the day before, you have to come in the next morning. We go through a symptom scale. We do another exam and either confirm that you did or did not have a concussion. And sometimes people come in with symptoms and we previously said they didn't have a concussion, and we switch it and we go through the protocol. Again, we say some of these injuries will bloom, and it's not uncommon to get symptoms delayed by a day or two. In order to get back to play, obviously we follow the graduated return to physical exertion, monitoring for symptoms. This is done under medical staff supervision. At some point, they have to be seen by the team's neuropsychologist and another doctor called the INC, which is the independent neurological consultant, which is different than the UNC or the unaffiliated neurological consultant. These people are office-based practitioners, and they're more or less called upon to confirm the fact that as a non-game day management piece of these, basically the UNC is a game day person, the INC is a post-game day person, to make sure that we're following the protocol and that the players are truly being managed appropriately. Usually that's a very quick visit. And then ultimately they have to go through the whole return to play protocol, be cleared by these two outside individuals, and then we can clear them appropriately for gameplay. Really, really fast, and then I'm done. How do we help reduce head injury? Head injuries in the NFL, there's a huge team of people at the league, researchers, biomechanists, lots of money that goes into this. I'm just going to give you 3 examples. First is sort of a coaching or technique example. This is lowering the head. Basically, this is heads up football. They did a video review of all head injuries in 2019, and they looked at the risk of cervical spine and concussion and tackling. In the top with the blue line shows that the striking player's cervical spine injury risk, as you move from left to right, from a heads up position to a flat back position, would increase. And when you fully lowered the helmet, you would have a 2 times increased risk of cervical spine injury. The person getting tackled, the struck player, as you move from left to right, went from their baseline risk of concussion up to 80 times greater risk for concussion if you got to this scenario on the right. So a lot of this is coaching and also rules that has helped sort of mitigate this risk. Helmet choice from an equipment standpoint, I was quite skeptical years ago that helmets would really make that big of a difference. I would say I'm less skeptical, but each year, the league recommends certain helmets. You can see through 17 and 18, more players were migrating over to the top performing helmets, which we're seeing in green. This is the list for this year. In the rule states, a player really can choose any helmet they want as long as it's not prohibited. So on this list, there's only one prohibited helmet. Special teams is an example of rule changes that has really decreased concussion incidents. This is the kickoff rules. And in the 2018, we saw a 38% reduction of kickoff concussions versus the preceding 3 years. And that the rules, they eliminated wedge blocks, and we really had far fewer concussions given the increased number of touchbacks. Blindside blocks and other injuries, these are very dangerous plays. Again, rules prohibiting blindside blocks should bear out in terms of decreasing risk, not just of head injuries, but many other, musculoskeletal injuries. As you can see here, 40% of serious injuries is defined as greater than 8 days lost were from blindside blocks. And 63% of blocks, punts were from the blindside blocks as well. So this has been really helpful, and the league has done a really good job of identifying rule changes and coaching techniques that can help mitigate concussion risks. So I'm not sure how long that took, but that's all I got, and we'll move on here.
Casey, very, very good. Awesome talk into the details of what really happens on the sidelines. I appreciate this. I have about 15 questions coming your way pretty soon because you brought up a lot of great points. Okay. We'll see Casey later on here. Okay, our next speaker. Our next speaker is Kevin Morley. He's an athletic trainer. He's 4 seasons into the head trainer position for the New Jersey Devils. He's spent 13 seasons with the Devils organization. He has his bachelor's of science with a major in health sciences from James Madison University in 1999, a master's degree at the University of Florida, and is presently working on his doctorate in athletic training from Florida International University. We found out that he was a pretty good swimmer and diver. So we tried to find some pictures of him swimming or diving. We couldn't find them, but we did find this little thing that showed all the records that he set. So he was pretty good. He was pretty good. So I wish we had some pictures of him. He's in his 4th season as a head trainer. He's a member of the Board of Certification Exam Development. So when you guys take your ATC exam, he's the guy who makes it tough. He was a previously assistant athletic trainer for Miami University at Ohio, worked with the ice hockey, baseball, cheerleading, tennis, and synchronized skating teams. So pretty diverse. He's worked on sports medicine staffs for various athletic events, including USA Hockey, the Red Bluff Cliff Diving, and Flutog competitions, which I'm going to let him explain to you because I've never heard of it before, but it's pretty fascinating on diving, as you see on the right-hand side there. Anything that's sponsored by Red Bull probably is going to be pretty tough. This is his wife, Katie, who resides in Madison, New Jersey, with their daughters, Aiden and Andon. You're up. As soon as I get off here. There we go.
All right, thanks, Stan. It's really an honor to be here, and I'm excited to represent the Devils and P-Hats and FIU. And so my charge here is, similar to Casey in terms of giving you a kind of a peek behind the curtain, what's happening in NFL. I'm going to talk a little bit about the NHL. And for as much as our games are obviously very different, our approach and some of the things that we're working on are very much the same. So I have nothing to disclose here. And so I think over time, concussion has really become the Pandora's box of sports medicine. It's that, when you have an MCL, everybody wants a piece of it. But when you say concussion, everybody turns around and looks at their phone. And it's kind of like this constant game of hot potato where there's the team physicians, the GP and the chiropractor and the orthopedic surgeon, and everybody kind of just looks at each other. And so as a result, we kind of bring everybody together and we coalesce into this treatment team. And I think what we need to remember from the perspective of athletic trainers and sports physical therapists is that we need to get all the stakeholders on board. And so as we talk about, I'm going to talk about protocol in terms of what the NHL has devised. And so when you're setting something up like that, it's really critical you get all your stakeholders involved. And so what I want to impart today is that the stakeholders in the NHL and the stakeholders in the NFL are different from each other. And likewise, the stakeholders in your high school or a small college or large college are all very different. And so what's important is that we don't take what Kevin said the NHL is doing and go plug it into our high school, because that's not realistic. What is realistic is to identify who the stakeholders are, your school board, your principal, whoever that may be at the collegiate level as well, and work together to decide what's realistic for you. And so whether that, with regard to diagnostic testing and different specialists and technologies and things like that. So to generate a system of evaluation, treatment, and return to play that everybody can agree on is really important. And that's really, I think, what sets you up for success. So with regard to the NHL and what we did, well, we didn't just Google it. If you Google concussion evaluation, you get 1.5 million hits. So it's not really that useful. But what we did in developing our protocol is that we started with the most recent guidelines. And so, of course, the consensus statement from Berlin in 2016 is what we're still working off of. They were going to meet again in Paris this year, which obviously is not happening as a result of the world falling apart. And so my understanding is that they're going to get together in Paris in 2021. And I'll call your attention to some of the names on the consensus statement from Berlin. The NHL, and I imagine the NFL and MLB as well, the NHL is really well represented here. And so folks who work for the league specifically, as well as folks taking care of our players at the team level, as well as some folks who are some of the independent people that we use and refer to outside. And so we really had a nice footprint and a really nice showing in the Berlin meeting. And so that was really enabling us to kind of take those things and bring them home and back to our clubs and back to our organization as we got together and determined what we do as a league. Of course, the SCAT-5 is something that came out of that meeting, and I'm not going to unpack that. The reason I bring it up is because this is something that we use. We've modified it a little bit at the NHL level, and so we have an app. There's always an app for that, right? So we have an app that the NHL uses proprietarily. And we've modified the SCAT-5 a little bit to kind of work within the framework of a hockey game. But that's something that we use, and again, with our goal always being comparing apples to apples, we can then compare a player to himself again later once an injury has either been sustained or suspected to have been sustained. So I'm going to get on a soapbox a couple of times, in the next 20 minutes or 25 minutes or so, depending on how fast I talk. This is the first one. I really don't like the word protocol, and I'm arguing semantics a little bit because I think what we're doing is obviously very important and really good, but I really hate the word protocol. I think it implies that there's one way of doing something. And everyone's favorite cliche, concussions are like snowflakes, and they are. And if you've seen one concussion, you've seen one concussion, right? And so I'm very hesitant to say, well, this is what we do and just check the box, follow the list, because I think that, that takes away, and we just lose sight of our clinical judgment. And so as athletic trainers, physical therapists, physicians, it's our job to get together. And certainly by all means, I'm for structure and I'm for having a regimen. And I'm for having some boxes to check, but I'm very leery when people talk about protocols and people say, well, he's in the protocol as if it's a place, and I don't know if protocol is like a town in Ontario, but when people say they're in the protocol, like my players don't go away for a month. If they have a concussion, I see them every day. So I have to say that that's one of the things that I always kind of cringe when people talk about protocols. I also just want to, make a lighthearted comment about assumptions. And so when you see something happen, when you see somebody get erased at center ice, it doesn't necessarily mean that they've had a concussion. A big hit is a big hit in football and baseball and hockey and soccer and every other sport. And I think what's important is that you evaluate your patient. And so, of course, there's a multitude of videos I could have taken from YouTube and from my own personal, photo stream. And I chose not to do that because I don't know if these people had concussions or not. And so just because there's a big hit, it doesn't mean anything necessarily. And I've seen people retire from just getting kind of knocked into in the corner. So I think we just have to be mindful of course, paying attention to what we see and watching the tape, but also just evaluating our patient. So with regard to the NHL's concussion management program, this is just kind of the first page of it, and it's not a document that I'm able to share, but I did want to highlight a couple of things. So this is from the NHL Sports Medicine Handbook, which comes out every year. It's revised, it's like CPR, they change it a little bit every year. So I think, this is just kind of the first page of the concussion portion of it. You'll notice that it references the Berlin Consensus Statement. Clearly references that this is an individualized process. Every situation is different, and it references that this is physician driven. And so you'll notice the two logos at the top, and that's really important because this is something that's been collectively bargained. And so collectively bargained is a buzzword for us, meaning that what are often two, combative entities, the league representing the owners and the players association representing the players, they don't always agree. In fact, more often than not, they don't, depending on the situation. So this is something that they have agreed on. Our group, PHATS, as well as the NHL Team Physician Society, had input here. And so, again, this is bringing me back to the stakeholders I mentioned before. All the stakeholders were involved in this. So we get a lot of questions about baseline testing and in-game testing. So the first thing that happens, the answer is yes, of course we do testing. And this is actually very similar to what was described in the NFL. There's an education session every year. That's a video. You can Google it, the video from this year. And it's really nicely done. The video from this year is available online. You can watch it. We use the SCAT, similarly to a lot of other leagues. As I mentioned, we have the app. So every fall during training camp, whenever training camp is this year, who knows? Every training camp, we repeat the SCAT 5 app to repeat each player's baseline, as well as we repeat their impact, and then a battery of paper and pencil test, Hopkins verbal learning, trail making, things like that. In-game testing, in the presence or suspicion of the presence of a concussion, we'll repeat that SCAT test, and that gives us a nice opportunity at the end to be able to compare that person in real time, what they've shown us today and what they showed us at baseline. And we can see their last couple of tests, and if they've had concussions before, we can put all those on top of each other and look at it. One comment or one question I get a lot is, can you just race through it so you've checked a box? The answer is no. The SCAT app has some things built in, especially for the delayed recall portion of it. You can't just click through so you can check a box and Big Brother thinks you've done your test. You have to wait a specified period of time. So you can't, if somebody leaves and comes back 30 seconds later, they have not been evaluated for a concussion. So we'll go through the SCAT app, and then of course, the most important piece of this exam is the medical evaluation, which is almost always done by the athletic trainer and the physician collaboratively. So in terms of in-game, I think this is kind of the part that's probably the most interesting for people. This is the spotter program. Spotters is a buzzword that the NFL, started, and we kind of jumped on board a few years later. It's not a public document right now. This was released in 2016. If you'd like to Google it, you can. It's changed a little bit since then, but really the nuts and bolts of what the league decided and again, what was collectively bargained back in 2016, the nuts and bolts of it are really largely still the same. When you talk about the spotters for the next few slides, this one is funny to me because it's the LA Times. It says the NHL empowers spotters to identify players with concussions and pull them from the game. And of course, there's Sidney Crosby talking to his coach. So he's not a spotter and he's not pulling him from the game. I want to make a point that this is not an adversarial relationship where the spotters are there as the judge and jury and they're pulling people from the games indiscriminately. It's really a collaborative effort. So what are the spotters looking for? In a minute, I'll tell you who the spotters are and kind of what they do. In terms of what they're looking for, I think that's an important piece of the puzzle to kind of explain. Here, the buzzword here is visible signs. Here's that collectively bargained again. So visible signs are a list of collectively bargained, it's a list of behaviors likely indicative of concussion, and they're not flexible for interpretation. So there's a list that's been collectively bargained, everybody agreed on it, and the presence of the visible signs necessitate either a mandatory evaluation or a discretionary evaluation. Hold on to that for a second, because I'll come back to that. The visible signs can be identified by the central league spotters or athletic trainers on the bench. And again, spotters are there to be adjunctive, and they're not judge and jury. So here's my opportunity to pick on the New York Islanders. This is a picture of the Barclays Center, which is a great building, but it can be tough. And so this is a picture that was all over the news and Twitter and things like that, because this picture was taken from someone's seat. And what you don't see is the goalie that's essentially underneath them. And so this is my reminder to talk about obstructed views. And so when I'm on the bench and when my colleagues are on the benches, we have the best seat in the house, and at times we have the worst seat in the house, because when I turn to one side, I see any number of assistant coaches. If my players are standing up, they're on skates, and some of them are 6'6", I can't see anything. Then when I look to one side, there's fans. When I look to the other side, I have Pierre Maguire and Bryce Salvador and Ray Ferraro and some of the different talking heads. And then when I look even further to the side, I see fans, usually with beer, telling me what they think about my team and the score. So there's a lot of things that I can't see and my colleagues can't see. So the spotter system is there to help us. So we started off with internal spotters, and we've moved to a central league spotting system, which has certainly improved our game and has really been able to augment us and give us and kind of prop us up and help us see things that we're not there to see. So the spotter system is not there to tell us you've done something wrong and you've missed it. It's there to tell you, hey, I know you didn't see this, but I did, and this is what's just happened. So the list of visible signs is not one that's for public consumption. We'll kind of hypothetically make up some here in the next few minutes, but there are quite a few articles about it. If I screen grabbed one for you if you'd like to read it. There's quite a few of them out there. So spotter workflow, what do they actually do? Who are they and what do they do and where do they sit and kind of what are the nuts and bolts of that? And the spotters are a bunch of certified athletic trainers. They've all worked in hockey at some level, and they're all in a studio in New York City. So they're sitting in the studio, they have a video person supporting them, and they've got lots of different angles. They have home feed and away feed and different internal house feeds. They have the blue line, the goal cam. They have all these different feeds. They have the ability to toggle between one and the other. They have the ability to zoom in and zoom out, rewind and fast forward very, very quickly. So they have a lot of information available to them, and they're watching again for those visible signs. As I mentioned before, visible signs live in one of two buckets. The presence of a certain group of physical signs live in a bucket called a mandatory evaluation, meaning that the epidemiologists have run the numbers and told us that the presence of these visible signs have the highest likelihood of being present in the situation where somebody's sustained a concussion. Then there's a second group that live in a bucket that's called the discretionary evaluation. These are still meaningful and these are still important, but the likelihood is a little bit less. So when we see those that live in the mandatory bucket, that person's going to get an evaluation no matter what. When we see something that lives in the discretionary bucket, it's just that, it's discretionary. Mandatory is mandatory, discretionary is discretionary. We revisit the definition of those words every year at training camp. Let's take a pause for a second. I'm going to pretend that we're in a conference room. Everybody's engaged and excited about concussions and sports medicine, and baseball's back, and we're starting to get our lives back together. And so I'm going to ask you a question, and I'm going to ask you, what do you think may be some visible signs? Again, it's not a list that I'm able to provide, but I'm just going to guess that this is an educated group, and you're shouting things back at me, and everybody's excited and jumping up and down. And one thing that we might see as athletic trainers, physical therapists, physicians, that might be a visible sign, might be like a dazed look, right? Like we'll call it dazed and confused, where they just look, they're kind of blank, vacant. We're not really sure if anybody's home. So that's potentially one. That would make a lot of sense. Another one is kind of the incoordination, that Bambi legs that are falling, especially all over the ice. That would make a lot of sense too. And then lastly, maybe they just kind of grab their head. That would make sense as well. So for the purposes of the rest of our discussion, we'll take that dazed look, we'll call it dazed and confused, and we'll work with that one as I explain kind of how this works from a communication perspective. So the folks in New York City in the studio, those are our central league spotters. And again, those folks are ATCs. They've been in hockey. They're watching with all the different cameras. We also have folks that are in arena. They're called the in-arena spotters. They are not athletic trainers. They have done some webinars. They do have a little bit of education. They're really a conduit. They're a communication vessel. And so they're helping communicate between us on the bench and the folks in New York City in the studio. So the communication goes from the in-arena spotter, from the central league spotter to the in-arena spotter to the staff on the bench. So hypothetically, how that might work would be if we've seen somebody with a big hit or potentially even a small hit, and they're slow to get up and maybe they have that dazed and confused look. Let's say the dazed and confused lives in the mandatory bucket. The central league spotter sees it. I may or may not see it. My staff might not see it. We're tending to blood and guts. And so the central league spotter sees dazed and confused. And they reach out directly to the in-arena spotter. They tell the in-arena spotter, New Jersey, number 99, dazed and confused, mandatory evaluation. The in-arena spotter repeats that back to them. The in-arena spotter is on radio with someone on my staff. Typically, it's not somebody on the bench because it's loud and it's hard to hear. Typically, it's somebody off of the bench, a massage therapist, an athletic trainer, a strength coach, somebody else who's certainly not sitting around doing nothing, but has a little bit more of a controlled environment. So the in-arena spotter communicates via radio to my staff. And again, New Jersey, number 99, mandatory evaluation, dazed and confused. The person on my staff then communicates that information directly to us on the bench. It sounds like a lot of steps. It kind of is a lot of steps. It actually happens pretty quickly. We're about 5 or so years deep into this system, and we've got it down pretty well. So there are a lot of people involved, but operationally that works pretty well. The in-arena spotter always physically comes to our locker room before the game, introduces himself or herself, hands us a radio. They mic check several times throughout the game. It works pretty well. From a video perspective, we have a couple opportunities to actually watch it if we haven't seen it in real life. If it's a big hit, usually they show it on the Jumbotron. If I want to see it again, I want to be able to rewind and things like that, I have two options. So two things happen kind of sort of at the same time. we have the NHL has contracted a secure video sharing service, and so within a few minutes, I'll get an email that says, "Hey, Kevin, there's a video clip waiting for you," and that's been after somebody has identified the Central League spotter has identified a visible sign, either discretionary or mandatory. So now I know that there's a video waiting for me. Additionally, I have a Hawkeye system. A Hawkeye system is a computer system, a computer video system that lives in every NHL home and away locker room across the league. And if we do neutral site games, it'll be there too. And so we're trained on how to use it. So what they'll do is they'll drop a bookmark. And so if there's been a visible sign identified, and I or someone on my staff wants to look at what they've seen, we'll come back into the athletic training room, again, home or away. There's a bookmark sitting there for us. We just click on it. It takes us straight to the spot in the video where the injury or where that visible sign has been present. We can fast forward, we can rewind, we can toggle between a few different views. So we have a couple different ways where we can look at that. The Hawkeye system is then dropped at the end of the game, but those secure clips that come to me via the video sharing service, those are there forever. So the purpose of this is not to be an a really significant unpacking of all the different systematic reviews and the research on the topics, but I do just want to give you a little bit of a heads up that certainly there are some research studies out there. Everybody wants to know about the rules. Of course, we're always changing the rules to make the game faster and more exciting, but we're also always changing the rules to make the game safer. So the first one is from the British Journal of Sports Medicine in 2014, looking at the incidence of injury in professional collegiate ice hockey. Are we making progress? Are we making progress? I don't really know. This study references that there hasn't been a gigantic change in the presence of concussion, the incidence of concussion in the groups measured. Secondly, the next one is a nice one. And now this is just looking at PEDS. Of course, there's some impact people involved in this study. And so this looks at the incident of concussion in youth hockey specifically, and compares youth hockey to other collision sports, football, lacrosse, things like that. They're pretty close. And I think it's interesting because, we play typically a lot more hockey games than you play football games. Lacrosse is a very regional sport, so not as many games played nationally. Internationally, of course, there are. This was a US-based study. Hockey compared to other collision sports, pretty similar. The last one from the Journal of Canadian Chiropractic Association is a really cool one, and thankfully from our Canadian friends north of the border, they kind of take a deeper dive back into the history of the NHL, the concussion management program that started way back in the late 90s. There, of course, was a deluge of concussions diagnosed, right at the onset of that. Were concussions present prior to that? Of course they were. They just, they weren't discussed and, and certainly weren't diagnosed. So it's a really kind of interesting article if you want to look at kind of more of like the historical side of the NHL and our concussion management programs. The last one, there's a lot going on here, so I wanted to just grab this one in isolation. This is another systematic review. This one does a really cool job of looking at lots of different things and kind of teasing out different studies. And so if you want to go down this rabbit hole, this is going to take you some time, but it's a really great study and gives you a lot of, fuel to kind of continue your investigations. This looks at position, of course. There's more forwards on the ice than there are defensemen, but the defensemen typically play more time than the forwards, depending on how successful you are. Goalies play a lot of time. They don't get hit that often. When they do, it looks like a major explosion. The forwards have more concussions than defensemen do. Defensemen have way more concussions than goalies do. So that's not really a surprise. However, in addition to teasing out the positions, it talks about the different mechanisms of injury. Contact to the head. Contact to the head with a rotational moment is the most common. And again, the willingness to report thing, I think, is certainly a topic that Stan and Nancy could, have us back to talk about in another webinar because we don't have time for that today. But as the, social and societal awareness of concussion has increased, so has the diagnosis of concussion increased. So it's like, well, there's more people with COVID because we're testing more people. Well, there's more people with concussions now because people are more willing to admit that they have these symptoms. Are there actually more concussions now? No, probably not. But people are more mindful of it. And as Dr. Batten mentioned previously, we have people, of course, self-reporting and even teammates reporting to, hey, you should go talk to him because he's not acting right. And those are the things that have increased over time, especially in the last 10 to 15 years. Now we've gotten more concussion diagnoses as a result of people being more mindful and more respectful of the disease. There is a discussion that's really interesting to be had about the size of players, and people say, well, the hockey, the players are getting so much bigger. Football as well. They're big and they're fast, and so they're hitting so hard you must have all these more concussions. The flip side is that, well, if they're bigger and stronger, then they should be able to attenuate those forces better, so maybe there's fewer concussions. So I don't necessarily have an answer to that, but I think it's really interesting to kind of just discuss internally. So here's another soapbox of mine because I have the mic. And so here's my personal experience. And so I'm going to give you my experience over 20 years or so in hockey is that forward skating through the neutral zone with their heads down, they're at the greatest risk. And so that poses them, they're at a significant risk. And one of the things that you'll notice is that there's a very large percentage, most of the concussions are sustained while either carrying the puck or within about 1/2 second after having released the puck. Goalies getting knocked over aren't at a significant elevated risk as you'd think, although it looks dangerous. When he gets exploded because somebody ran into him, the net actually falls off the pegs relatively easily. People slide on ice, which is not to minimize the magnitude of the collision, because I gasp at them sometimes as well. The reality is that the epidemiology and the studies are pretty clear that the incidence of concussion in goalie in those situations, it's not zero, but it is very, very low. Defensemen admiring their breakout passes should pick their head up, similarly to the forwards in the neutral zone. With regards to the rule changes I mentioned before, changes in icing rules recently have certainly had the most meaningful impact as opposed to other changes. And so that has made our game safer. I've seen femoral fractures. I've seen all sorts of stuff from that, previously, and our game is absolutely safer as a result. Fighting at the fighting question a lot. Fighting is largely gone from the game. It just doesn't happen that much anymore. And it really wasn't a major contributor to concussions. It gave us all the dental injuries, TMJ, facial lacerations, cervicogenic disease, all sorts of problems. But it really didn't give us a really gigantic number of concussions. Players who have had multiple concussions certainly are at elevated risk, and certainly those who have had concussions recently are at great risk. That's certainly another webinar. And then, the ultimate $1 million, $1 billion question is how many is too many? I certainly don't know, but it's absolutely a very real concern. So as I finish up, I'm not going to talk a lot about the return to play guideline, but I do want to just kind of pump the tires of the NHL a little bit because I think they did a really nice job in the most recent CBA as we talked about the RTP criteria because of what it doesn't have. And it doesn't have a lot of rules. It doesn't have criteria. It doesn't have timelines. It doesn't have dates. What it basically says is, in truth, a very, very common sense approach is that you got to crawl before you can walk. So let's get these people asymptomatic or mostly asymptomatic. Let's not put them in a dark room and tell them to come back in a week. Let's engage them with their teammates, with their friends. Again, I don't work in a collegiate environment or school-based environment where I have to worry about screen time. I might have to worry about how many documentaries they're watching or video games they're playing. I don't have to worry about them going to school. I don't have to worry about group projects and lectures and staying up late for homework and papers and things like that. So, be mindful of engaging them with their team. For many of these folks are international, English may be their second language. And so there's a lot of different social things that we have to keep in mind. But the return to play criteria really does a nice job of giving us the autonomy to make smart decisions and progress through this in a mindful fashion. But it's really stepwise. You just take one step at a time. And if it's not going that well, then you just stop where you are. So I have a great group of people surrounding me who I work with, and certainly across the NHL. And, everybody I know, we have, really, really collaborative environments. And so again, going back to the stakeholders I started with at the beginning on that game of hot potato, it's really important to involve everybody. So what the RTP does require is that, like Dr. Batten mentioned in the NFL, we repeat neuropsych testing as well. We have an independent neuropsychologist who we work with. They have a great group, and we've done that on the road and with other groups across the NHL. So we do repeat that, and we do look at that. Again, that person is also not the judge and jury. This is a collaborative environment where we work together and we're medically driven, but that's a gigantic piece of the puzzle. We repeat the paper and pencil testing as well. I mentioned the SCAT. We also oftentimes will do the SCAT serially along the way, just from a symptoms score perspective, just to measure incremental changes. I think that's been really useful to us. And obviously the medical evaluation, Gen Med, Neuro, PM&R, sports neurology. We're gifted to have, some really great sports neurology folks near us who I'm really, really pleased to work with. But again, these are the document, I'm not going to share, it doesn't really matter, but the document, again, has been generated by all these stakeholders. And so if we look at it, it's got general managers, it's got players, it's got attorneys, it's got coaches, it's got athletic trainers and physicians. So everybody agrees that we're all in this together, and this is really, the best way to approach this. On the way out, I have to just mention a couple other considerations, is that things that are always, this is really your differential diagnosis slide, which could have been at the beginning or at the end. So many pathologies that present with similar symptoms as concussion. And so I read a study that took the SCAT symptom score from people with concussion or suspected concussion and gave it to physicians, athletic trainers, physical therapists who were blinded to the pathology or blinded to the accident. And they said, what's wrong with this patient? And these folks came back and said, oh, this patient has depression. This patient has anxiety. This patient has a migraine, cervicogenic. You get my point. And so all of those things are real, and you can absolutely treat almost all of those things. And so It's important to be mindful of the 360 approach and really looking at the whole patient. And we've thankfully come a long way from just taking them, locking them in a room, and seeing a week when your headache's gone, because we can treat so many of those things and help them make their headache be gone. Of course, there's always the issue of, do they want to play? And based on what they're telling you and what their parents and their spouse and everybody else is telling you, certainly your hands are tied in a lot of those situations. Again, that's probably webinar number 4 that I've proposed, but all of these things really come into play. And so my final list of thoughts is that, concussions can be treated, as I just mentioned. I think that not treating them is negligent, because there's so many symptoms that are contributory. And so I can't tell you how much time our massage therapist spends on, half the time with the lights off, or with the lights, in a dimly lit room, with some quiet music playing, because we're working on, upper traps and all the different, deep neck flexors and all the different ART techniques that we can use, and manual therapies and needles and all the different things, because those are all pain generators. And so it's difficult. It's easy for me to say, well, you have a headache, so go away and come back when your headache's gone. Because you throw my hands up in the air, I can't treat your headache, but I absolutely can treat your headache. I might not be able to magically make your concussion go away, but I can absolutely treat your neck pain. And in so doing, maybe we're spinning our wheels and letting the concussion resolve, but also maybe we're helping your headache go away. And that's part of our job. And so I think as we consider all of those musculoskeletal issues, we have to consider, you can't overlook the vestibular system, and we can start training those things as well. And we have to look at the cervical spine, because so often it's that whole analogy of like the golf ball on the tee, is that we can treat all those things and really, really help our patients. So, for me, again, we're gifted, because we live, where we live, and we have a wonderful, wonderful medical community, but I think everybody has people that they can draw on and really involved in the treatment team. And I think that's really, for me, kind of my take-home message to you, is that protocols are very interesting, and what everybody does at the different levels is great. But you have to operationalize and protocolize what's realistic for you and your team, and then identify what interventions you and your team can make, because that's really what's helping our patients get better. And that's the whole goal of the concussion management system. It's not to just go lock you in a room. The whole idea is to help patients get better. So that's kind of a look behind the curtain into the NHL and how we approach it. I think what's been interesting for me with regard to looking at the NFL is that as much as our games are very different, how we're approaching things actually there's a lot of commonality there. So, we'll save our questions for the end, but thanks, Dan. I've really enjoyed being here, and I hope I've given people some interesting intel.
Kevin, excellent, just excellent. We got Gary Green up next. Dr. Green has been in meetings since he's worth the MLB. He's got a few things juggling in the air, but he's going to have a tough job after these 2 presentations. I got to tell you, Gary, there were 2 excellent presentations on this, and a couple things that I want to talk about as I introduce, if I get to my Zoom introduction here. A couple disclosures. I've known Gary Green for longer than I want to thank. Nancy, is Gary on?
Yeah, he is.
Okay.
You'll see him in a second.
Good. All right. So I've known Gary Green for, I guess, 20 years. I don't know. He's been the medical director of Major League Baseball for a long time. And as a head trainer, we dealt with Dr. Green on a variety of things. He's also not just the medical director of Major League Baseball, but he's also MLB research director, of which I've served on some of those committees. So I do have disclosure that I will butter him up because I want research papers approved. Anyway, that's my disclosures on that. Dr. Green got his MD degree at Hahnemann University, Drexel University, his internship at the Medical College of Pennsylvania Hospitals, did his residency at Christiana Hospital, I said that wrong, Medical College of Pennsylvania, sorry. He is the medical director of Major League Baseball. It has been, I don't know for how long, 15 years maybe?
10 years.
10 years, boy, goes fast. He's board certified in both internal medicine and sports medicine, and is a fellow of American College of Physicians and American College of Sports Medicine. He's also a clinical professor at UCLA School of Medicine in the Division of Sports Medicine. He's the advisory committee for PitchSmart, which is a app we've put out in regards to youth baseball. But again, he does a lot more than that in regards to the research that he does, but also coordinating all the research in Major League Baseball. He's on review boards for USADA, and he maintains a clinical practice in sports medicine and internal medicine at the St. John's Partners in the Pacific Palisades, California. He's a head team physician previously for the Pepperdine University, and head team physician for U.S. Soccer. And he's just joined the St. John's Physician Partners in Pacific Palisades. So he's going to be talking about an MLB program in regards to concussions, which was one of the earlier programs that were put into place, even though people don't think concussions happen very much in baseball. They do, in fact, occur, even though it's not a, quote, collision sport. This is his wife, Debbie, his daughters, Mia and Nina, and his dad is 90 years young. Gary, you're on.
Thank you. Wow. Well, that's quite an introduction. And Stan, just submit your things. We'll make sure those things all get approved.
Everybody heard that. Okay.
Yeah. So let me find my screen here. Too many things open here. No, that's not it. No, hold on one sec. Here we go. Oh. Okay, here we go. Is that coming across, Stan?
Not yet.
Oh,
Not yet. You had it, and then you try to share it again.
okay. Shoot, where's the share screen?
At the bottom, yeah.
Yep, but oh, here we go. Okay. Yep, you got it?
There you go. There you go. Good.
Okay. Well, thank you very much. That was quite an introduction, Stan, and I appreciate it. I'll try and follow these other great speakers to do this. I also want to say thank you to Stan and all the people who are joining in. It's also really a pleasure not to talk about coronavirus right now, and it's really nice to talk about something else for at least a little bit there, but we can talk about that a little bit at the end. So just want to talk to you about the MLB experience and where we've come with concussions and some of the research that we've done. Let's see, it's not advancing here. Here we go. Okay, no disclosures except for I work for MLB. So we'll talk about a little bit the MLB injury protocols, the stuff we're doing for pitcher head protection, the injury surveillance, effective rule changes in performance and return to play. So with the concussion assessment, I'm sure that the other speakers have gone over this. It's basically having a high degree of suspicion for potential head injuries. Using the SCAT-5, again, about 25% of our players are mainly Spanish speaking. So we had to translate the SCAT-5 into Spanish, which you think would just be easy. You just put it up to Google Translate and then it goes through. But the word choices and the word recalls had to be done by a linguist, a group of linguists, because a lot of the SCAT-5 depends on the frequency with which a word appears in that language, and also the number of syllables. So for example, sugar, 2-syllable word in English, 3 syllables in Spanish. So that actually it took quite a bit of validation to do that. It's important to remember that the SCAT-5 takes at least 10 minutes to complete. And why is that important? Well, because the media is very high on concussions. They watch it very closely. So if a player gets a potential head injury, they go in, they come out of the dugout in 5 minutes, you may get a question from the reporters is, how come it takes you 5 minutes to do it when it takes everybody else 10 minutes? The symptom checklist should be done in a resting state. They should read the symptoms out loud. We recommend using the 10-word option because players were memorizing the 5-word option, and it makes it a little bit easier. There are some, like the NCAA uses the SCAT-5 and some of it's as a baseline. It really wasn't designed for that. It was designed as an assessment, but people do use it for that. I was on a panel with a group of international experts from around the world from different sports, and we came up with these signs for immediate removal. And anybody that's done sports realizes these are pretty obvious. If someone's lying motionless, motor coordination, seizures, tonic posturing, no protective action, and a blank vacant look, those should probably be removed for further evaluation. I think that's a pretty much of a no-brainer. And many sports are using video to help in the assessment of this to see if these things happen, because a lot of sports, there's a lot of different things going on. You can't watch everything. We use the neuropsych testing. We use the impact testing. It's important that players should be asymptomatic when doing their baseline impact. When do you repeat it? Well, we recommend anyone who's had a concussion in the previous season. Catchers, because as I'll talk about in a minute, have a higher rate of both subconcussive and concussive forces, so we do those annually. And then it's a little hard to know when to do them, but if a first baseline was done prior to age 21, we recommend repeating it at age 25. We have to be clear when you're doing the impact that these mean current symptoms, not just if you've ever had them. So for the Major League concussion protocol, there's the when a concussion is diagnosed, there's a concussion assessment form and a SCAT-5, and then they can be put on the 7-day injury list, the 10, or no, they don't have to go onto an injury list at all. They all get submitted to the 7-day IL at MLB.com, regardless of whether this occurred when they were on minor league assignment. For the minor leagues, they go to the minor league MTBI at MLB.com. Again, this is for all players in the minor and also the Dominican leagues as well. So we have two different protocols depending on whether they're a 40-man or not, because if they're a 40-man player, they're part of the MLB Players Association. So in the return to play in the majors, there's a return to play form, the baseline, the most recent impact testing, and they do have to be physically examined by a physician. They can use the home team, as opposed to the NFL. MLB physicians don't typically travel with their teams, so it's important to make sure they are examined. And then after that, they get submitted, and then it gets reviewed actually by myself as well as a physician from the MLB Players Association, and we both have to agree. If there's a disagreement, there can be which there hasn't been in 9 years, but if there is, they can go to an independent third-party neurologist to be the decider. For the minor league players, it's almost exactly the same, except that they don't need to go through the Players Association because they're not part of the union. It's really important on the return to play protocol, similar to other sports, that they have an initial period of physical and cognitive rest. We start with light activity, daily symptom score, and then a 6-step return to play that's generally 24 hours per step, which means that this is typically a minimum of 6 to 7 days. We have, with very minor concussions, we have returned them prior to 7 days, but we're going to be a little bit more scrutinizing of those that are a little bit more rapid. And it's also really important to say that concussed players, or even potentially concussed players, should not be doing media interviews. And there's several reasons for that. One is, if you've had a concussion, going under lights and being asked difficult questions is probably not the best thing for a concussion. And in addition, players will often say things that maybe are not completely accurate in order to kind of make themselves feel better and look better, but don't always reflect very well on the medical team. So for example, a player might say, "Oh, I was out on my feet. I shouldn't have even been in the game, but I really stayed in there to tough it out." And this is the case where, the player's been actually evaluated several times throughout the game and passed all the SCAT, and it leads to a lot of questioning of the medical staff. So we recommend not doing media interviews at that time. This is from the SCAT-5. It's the general return to sport strategy. Again, these are just guidelines. These are not mandatory, but they're just basically guidelines for all sports, but certainly things can be advanced if people are doing well. And it's also really important to educate players about concussion. So educating them towards the signs and symptoms of concussions, how to prevent concussions, what to do if they think they have one, and really importantly, what to do with an injured player and don't move them. And then the other one is keep the area clean. So I put this slide up not to, some of you may know George Poulis from the Braves, and George was doing an excellent job of assessing his pitcher who had gotten hit with a line drive. But I put those arrows for all those people that should not be in the picture. The area needs to be clear, and this is for all injuries, but the area needs to be clear so that the athletic trainer has good sight lines in case they need to call for a cart, emergency services, or a physician to come on the field. But none of those people needed to be on the on the field at that time, and the area should be kept clear. So for those of you who are not familiar with baseball, the majors and minor league systems, in the majors we have 30 clubs, most years with 1,200 players. They play games very frequently, and the minors have about 7,500 players in most years, except for this year, with varying season lengths. So in 2010, we created a league-wide electronic medical record system for all clubs, majors and minors. And the data is used to import a health and injury tracking system that allows us to really track injuries and do our research projects. And this was a few years ago. We'd had over 100,000 injuries. It's probably 150,000 at this point. And this allows us to do very robust injury surveillance. So here's the problem with catastrophic injuries in MLB as opposed to maybe other sports, that there's 750,000 pitches per year in the majors, and there's 10 potentially catastrophic injuries per season. So that's 1/1000th of the time. However, the athletic trainers and the physicians have to be prepared 100% of the time. And so because unfortunately they don't tell us which one of those pitches is going to result in a potentially catastrophic injury, and we have to be prepared for every one. And that creates a difficult issue in terms of doing emergency preparedness. And it's often a matter of inches. If you can see the ball right here, who struck Brandon McCarthy right here on the temple, he ended up with an epidural hematoma, and was fortunate enough that had brain surgery and survived that. And this is opposed to another pitcher who got hit in almost the same area, Doug Fister in the World Series. And you can see that it's just a matter of inches. In this case, the ball kind of cue balled off his head and went into the outfield, and he was actually fine. Had a little scratch on his forehead, but actually stayed in the game and did not have a concussion at all. So it really, and obviously if you were standing on the sidelines, you would have a very difficult time distinguishing those two. But it's really sometimes just a matter of a few inches between life and death in this situation. And here's a example of Aroldis Chapman, who got hit in spring training about 6 years ago. And you can see on the enhanced CAT scan, here's the ball. You can see here's the impact that the ball made on his skull. And luckily, he didn't have any eye damage, and obviously still pitching, and had a surgery to fix that depression fracture. And so as a result of that, we really tried to find a good way to protect pitchers, because they have very little time to protect themselves. And the first thing we came up with was the Isoblox prototype. And Alex Torres was the first player to wear this, and unfortunately the only player. He got a lot of teasing. He was called Super Mario by some of his colleagues, and his hat actually went to the Hall of Fame. Unfortunately, he didn't, but the hat did. But this did not get a widespread acceptance, as you can imagine, in MLB. We then worked with the Players Association, coming up with a second version, which also was not very popular. And then we came up with a carbon filament cap that looked more like a regular cap. We made several prototypes in spring training a few years ago, but again, could not get any of the pitchers to wear this. And the key for these hats is it's right here on the dominant side of the person's dominant arm, because pitchers tend to get hit right there when they turn their body when they're throwing a pitch. And that's unfortunately where the middle meningeal artery runs, and you can get an epidural or subdural hematoma. Again, and when it comes to pitcher head protection, we're still working on it. We've tried different prototypes. It's just very hard to get pitchers who are at the major league level to change their routines. And there's even a question of whether our helmet's really the answer. If I was there in front of you, I would ask anybody, did anybody know which kind of helmet, which sport this is in? And anybody that gets this would get some M&Ms. But this is a cricket helmet. And despite that, Philip Hughes, an Aussie cricket star, he died about 6 years ago when the ball hit the ground, reflected back up, and hit him just below the back of the helmet, dissected his vertebral artery, and he unfortunately died. So even with extensive cricket helmets, can't necessarily prevent a catastrophic injury. So one of the first studies we did using the HIT system was looking at the epidemiology of concussion in major and minor league baseball. And this was published about 5 years ago. And what we looked at is over 2 seasons, we had 314 concussions, the majority in the minor leagues, 50 in the major leagues. As you can imagine, the average age of the concussions was slightly higher in the major leagues with older players. And what we did was we broke it down to athlete exposures. So about 138,000 athlete exposures. So an athlete exposure is one athlete in one game, about 500,000 in the minors. And then we broke it down. The rate was about 0.26 per thousand, which is about once every 220 games in the majors, a little about double that in the minors, and 98.4% occurred in games. The NCAA game rate was lower, but I think some of the reasons for that is that this was done up until 2004. Concussions probably weren't as recognized at that point. And not surprising, anybody that's covered baseball, we have relatively few practices. And when we have practices, they're generally at low risk for concussion. So most of these occurred in games. And then we broke it down to level of play. And as you can see in the far column, we had suspected that there would be more concussions in the lower minors, but actually that's not the case. And it's also interesting that the number of days missed was actually about the same, regardless of level of play. The location on the field, not surprising for anybody that's covered baseball, about 50% occur at home plate. And that was true across both the majors and the minors. And then we looked at offense versus defense. And so if you look at it, the about majority of more cases on defense than in offense, but there was no statistical difference in terms of time lost. So it was both about the same number of days, regardless as to where this, when it occurred in offense or defense. So we drilled down a little bit further onto the defensive concussions, since that seemed to be where the majority were. And then again, about 40 to 50% of the concussions on defense were in catchers, which again, should not be surprising to anybody that has that. And not only was it percentage-wise more, but if you think about it, pitchers and catchers are 1/9 of the positions. And if it was an even distribution, you would expect the catchers to be about 1/9, or maybe, about 15%, but actually they're about 40 to 50%. So you can see that catchers were statistically overrepresented with respect to concussions. So we drilled down one more to see where these happened. And what it turned out was that about 40% of the concussions that occurred in catchers who were on defense occurred with collisions. So catchers were more frequently concussed, and they were more frequently with home plate collisions. So that led to a further discussion about how to make a rule change on home plate collisions. So here's hopefully this starts. This was prior to the rule change. This was in the minor leagues prior to the rule change. So just watch the catcher. It's going to be 2 men on base, and it's hit to the outfield. So watch the catcher where he's standing. So first runner scores. So you can watch from another view. This is from a view behind home plate. And you'll see that the catcher, when he receives the ball, was actually not blocking the plate, was standing actually in front of the plate, had not received the ball as yet. So you can see that, the runner made no attempt to touch the base. He actually even had to go back and touch the base afterwards, because he was clearly targeting the catcher, and that catcher did end up with a concussion. So based on that, in 2014, MLB initiated Rule 7.13, which that a runner attempting to score may not deviate from his direct path to the plate to initiate contact. And unless the catcher's in the possession of the ball, the catcher cannot block the pathway of the runner as he's attempting to score. And this has been put into play. And actually, when we put the rule change in, we got a lot of negative comments. Pete Rose said, "What's the game coming to? The guys making these rules never played baseball." And he said, "I got lightheaded how many times in my career?" Yeah, probably a lot. And no more home plate collisions. What is this? And then a catcher said, "Nothing better than getting run over and showing the umpire the ball, and a bunch of effing nerds running the game." So you could see that I was not really popular at that time because people did not like the rule. However, this has now come into play. It's now been 5 or 6 years since this has been put into play. This was a play from the playoffs a few years ago where The runner was actually initially called out, but then he was reversed safe because the catcher was illegally blocking the plate. And then just to show you, oh, sorry. Oh, I thought I had a slide here. Just to show you, a year or two ago, we had last year we had a player for the Angels who got run over at home plate by one of the Astros. And that player was actually called out and was suspended for violating the rule. And we had just a massive outpouring of players supporting the rule and justifying that. So I think that there has been a change in attitude, which is kind of rewarding, that the players have now adapted to that and realize that you can't just run over somebody. You can't do that at other bases. Why should you be able to do that at home plate? So what we were able to do actually is we looked at the injuries and what happened after the rule was changed. And what we found was, again, how we changed the rule was we adopted the electronic medical system in 2010 after conversations with the late Dr. Yoakum and also with the still alive Dr. Adams. We started putting together this potential rule change. In 2011, we had the Buster Posey injury. MLB convened an MTBI committee. We reviewed the data, and based on that, Rule 713 was adopted. And this is concussions due to home plate collisions per season. The red is MLB, the blue is minor. And you can see that prior to the rule change, there were about 11 concussions per year. That dropped down to 2, with none in the major leagues. And if you look at the days missed, 276 days missed per season, down to 36 days. So a dramatic decrease in number of days lost. But it didn't just affect concussions, it also affected other injuries as well. So we had 100 injuries per year due to home plate injuries prior to the rule change, 55 after. And look at the number of days missed, over 2,000 days missed per year. That's not just over that course of those 4 years, but per year dropped to 936. So more than a 50% reduction in injuries due to home plate collision. So you can see that the rule not only reduced concussions, but also injuries. And so the strengths of this study it was a very simple study. It was probably the easiest study I've ever done. It was one variable. And the nice thing was there were no other changes to the game in terms of equipment, other rule changes, number of players, number of teams. It was a controlled environment, and we had a consistent concussion and injury reporting system. The limitations were a relatively small number of injuries, which is that's in baseball, that's what we have. We didn't necessarily account for season-ending injuries, although prior to the rule change, there were 19% of the injuries were season-ending versus 0% afterwards. So you'd think that the difference would probably be even more so if season-ending injuries were included. And then there's always a possibility that we missed some of these where a catcher failed to report symptoms, but there's no evidence that that's any more or less than it was prior to the injury. And as the previous speaker said, there's better monitoring of this now. And then there's always the possibility of misdiagnoses. So the conclusions that we found were that rule changes can have a major impact on injury pattern, but changing a rule can be very challenging. But in order to affect a rule change, what you need is objective, well-researched data, support from the sports governing body, collaboration with all the stakeholders, excellent research partners, and then a lot of patience, because it can take time. And again, this was the slide that this was after Josh Reddick ran over Jonathan Lucroy. And you can see that it's changed. MLB needs to take action on this, praying for Lucroy. If you think this is okay, F you. So, again, I think that Yadier Molina was was a dean of catchers and was certainly considered old school, yet he was really supportive of the rule at this point. So last study that I'll mention is one that has not been published. It's been submitted for publication, hopefully gets submitted soon. But the next step in research is we've done a really good job in baseball of looking at epidemiologic studies. So we've kind of categorized and cataloged concussions and other injuries as to when they occur, where they occur, what position, how long they're out for. We've done a really good job of the demographics. And the next challenge is looking at what's recovery. Because we're all concerned, are we letting people go back too soon where they might be medically cleared, but they're not athletically cleared? And what happens to them when they go back, and how do we measure performance? So what we did is we took all of the MLB position players who had a confirmed concussion over 2011 to 2015, and we looked at 7 batting metrics, batting average, on base percentage, slugging percentage, OPS, base on balls, strikeouts, and home runs. And then we calculated for each player their statistics 60, 30, and 14 days prior, as well as 14, 30, and 60 days after. And we controlled for defensive position, age, number of days missed, mechanism of injury, and whether they did a rehab stint, and then what year the injury occurred. The other thing that this was a really important contribution to the literature is we realized that you need an adequate sample size in order to do this. So we looked at all players and we determined what's the 90th percentile for all players in plate appearances per game. So for 14 days, it was 20, which is 1.6 per game. For 30 games, it's 1.5, and for 60, it's 1.2. And these were established as thresholds because you need an adequate sample size. It's really clear, like for example, in the beginning of the season, when a player only has a few at-bats, these statistics are not very useful. So in order to have a good comparison, we needed an adequate sample size. And these are the overall results. We had 77 concussions, and as you can see from our previous data, catchers were overrepresented at about 40%. And then the mechanism was collision, hit by a pitch or a ball. Some were missing. 29% went on a rehab assignment, and the average days missed was about the same as that we saw in our previous study, about 11 days, and the average age was about the same, about 29. So this is kind of an algorithm of our characteristics. So we had 60, in the red box to your left, we had 63 people that met the plate appearance criteria before injury, and then we had 48 that met it after injury, and the 15 that did not. We had 14 that did not meet the criteria prior to injury in terms of number of plate appearances, and then there were 5 that did meet it after and 9 that did not. And so here are the results. This is kind of a busy slide, but basically what we found was that for those players that met the criteria before and after, and that's that first column, that 48 cases, the number of plate appearances per game stayed very similar, 3.4 before, 3.5 after, and this is the 30 days prior to and after. And for those players that did not reach threshold afterwards, you can see theirs dropped, although there was a big statistical significance between these two groups prior to their injury. But all of the batting metrics stayed pretty much the same. There was very little statistical difference between their batting metrics both before and after for all the groups. So our conclusion was that position players, and obviously we excluded pitchers for this since they don't bat in most leagues, and in other ones they're obviously, they don't have enough at bats. So position players who are medically cleared to return to play perform at about the same offensive levels for their pre-injury statistics when you control for an adequate number of plate appearances to compare. And it reinforces the importance of using an adequate number of plate appearances in order to document the impacts on performance. So it does seem like in MLB, under our concussion protocols, players who are medically cleared also appear to be athletically ready. And it also is clear that players tend to return to their previous role on the team after injury in terms of playing time. Those players who were role players before become role players after. Those players who were starters before tend to go back to their starting roles. There are obviously limitations. Obviously does not apply to pitchers. It's only limited to the major league players. Relatively small sample size given the relatively few number of concussions in baseball. It's possible that 60 days was not enough, and maybe if you looked at 90 days or 120 days, there may be other effects, although we don't think that's the reason. And then again, players who had more extensive playing time return to their previous roles. It's possible that those players who had reduced roles or were on the team, it takes them longer to get back to their position. And there's lots of reasons for not returning to their previous plate appearances per game. It could be that they weren't playing well. Maybe they weren't resolved from their concussion. Maybe they lost the position on their team due to injury, manager's decisions, replacement maybe did well, platooning, and it just could be random chance, or it could be a contract issue, or it could be that the team's out of the playoffs and they're playing, younger players. So there's a lot of potential reasons for this, but I think that it really does show that, those players who returned basically did as well as they did before. The other thing that we did in MLB is we changed in 2011 to the 15-day disabled list to a 7-day disabled list. And again, for concussions. And again, this was based on data. We found in our HITS data that 40% of concussions resolved in 5 days, 70% were in 1 to 10 days. So the problem was if you had only a 15-day disabled list, teams were basically not putting players on the disabled list and they were leaving them on the active roster. And the problem that that caused was you had a player who wasn't available to play, but was taking up a roster spot on the 25-man roster. So if they were starting to feel better in a few days, and let's say all of a sudden they needed a left-handed pinch hitter, you know, the manager would go up to the player and say, "How are you feeling?" And they'd say, "Oh, I'm feeling fine." And they would put them back in. So we decided to institute a 7-day DL for concussions only. And it had a big effect. If you look at prior to the rule change in 2011, prior to the rule change, we had about 4.6 placements for concussion per year, anywhere from 2 to 8. After the rule change, we had about 11 or 14 per year. And if you can look at it, the 7-day was really what accounted for all of the extra DL days. The other 15 and 60 days stayed about the same. So this was an effect where players now had the opportunity to not be on the active roster and still be able to play. So that's my talk. If anybody has questions that we don't get answered today, please feel free to email me with any questions. I'd be happy to answer them. And I wanted to thank Stan and Nancy and a lot of my collaborators for helping me with this research. So thank you very much, Stan.
Thank you. Thank you. Nancy, can you? Yeah, thank you. So we got everybody back. We got about 15 or 20 minutes for some questions. A couple of things before we get into the audience questions. In the NFL, we've got pretty good data from baseball that catchers are the highest incidence of concussions, and a great study in the NHL showed exactly where people get hurt and which position. I've not seen anything on the NFL. Casey, have you got anything on what particular, is there a position? You know, I always think linebackers must be the ones that get hurt the most from a concussion. Has anybody done a study on that?
Yeah, can you hear me all right?
Yes.
Yeah, I wish I had a slide on that. It's probably somewhere buried in my computer, but it depends on how you're, like, numbers or risk, but right, it's actually offensive linemen, defensive linemen, linebackers, and then kind of defensive backs. Yeah. It's mostly defensive players. And it also depend on what time of year you're talking about. So we saw a lot of people in practice. So in camp, a large number was actually offensive linemen. So it kind of depends on kind of what scenario you're talking about and over the whole year. But yeah, there's tons of data on that.
Yeah, and follow up to that, you just mentioned practice. What kind of percentage of the total happened in practice? I know they've really shut down a lot of the hitting in practices, but how's that work out? Do you know any of those numbers?
Off the top of my head, no, it's less. Coming from college to the professional ranks, I mean, the amount of contact in the NFL practice is, I don't want to say zero, but it's exceedingly low. So usually, again, when we see the most, a lot of it is in camp, and it usually is not the starters, special teams periods, and some of the 7-on-7s where the linemen aren't able to use all of their technique because they're not in full pads, and sometimes they have injuries.
Okay, and Kevin, in regards to your spotters, I wanted to get some clarification on that. You've got two ATCs in New York City looking at video, and then you have the sort of runners, if you will, to get you the information. So in any given day, does those spotters watch multiple games, or have you got a whole team of them in New York City?
There's a bunch of them. I'm actually not sure exactly how many there are, because especially when you get into the weekend and you have, Hockey Night in Canada, and, there's a lot of games. We play 82 games, and there's 31 going on 32 teams coming up here. So there's a lot of games. The league keeps the very specific answer to that question pretty close to the vest. The answer to your question is, I believe that I know there's a bunch of spotters. Are they watching multiple games at a time? Probably, but I don't know that for a fact. I do know that our player safety department has some people who don't have the nomenclature of a spotter, but who are kind of assistive in that role, who are also watching games and maybe assisting the spotters and saying, hey, I'm not making this decision, but you should check this out because I don't know if you're going to be very comfortable with this. So the actual operations of how that happens in New York, I don't know. I'm not privy to that because I'm not there, obviously. But there is a lot going on. It is absolutely happening. Yeah.
Interesting. Nancy, why don't we get one from the audience?
Okay, this one's for Dr. Batten. Do you have any experience with helmet sensors such as the HITS system or G-Force? If so, have you seen any validity to the data collected and its ability to help with the diagnosis of concussions?
Sure. Oh, and I just to clarify my last answer. So I forgot to say cornerbacks, which is probably the number one most injured. But yeah, it's the linebackers, corners, offensive linemen, and depending on the year and where you're at, receivers. So in terms of helmet sensors, pretty familiar with the ones that are, fitted in the mouth guard or on the patch or in the helmet. A lot of those have really been for research only. There hasn't been a lot of real-time use. Part of that reason was there's a big issue in its accuracy of detection of angular acceleration, which really is seen in a lot of these injuries. We are starting to, in the NFL, is supposed to be this year, and I think some of the COVID might have derailed it. A few teams, including us, we're going to start using a helmeted-based system, a mouth guard-based system looking at this, but it's not really prime time yet in terms of a certain threshold at a certain force level that says you have a concussion or not. It's really kind of gathering data, look at how much force is really seen throughout a practice, throughout a game, in what positions, and really kind of looking at subconcussive blows and the overall kind of load. So nothing of it is prime time. A lot of it is partly because the sensors just weren't quite good enough yet. But I'll have more to probably tell you in a year or two after we've used them a little bit and looked at it. But really, it's been a research tool.
Yeah, I would also agree with Casey. I'm on the CIF sports committee, and that's come up a lot. And a lot of high schools, unfortunately, I think wrongly invested in these as a way of reassuring parents that their kid wasn't getting concussed. And when I review for journals and I see papers that have used these, you really have to follow them up with video and with because a lot of them you have false negatives, you have false positives, and I think you have. When I never accept an article that doesn't have video as well as clinical data on this, because I think that it really overrepresents it. And I think you're exactly right, Casey. I don't think this is ready for prime time use. It's still a research tool in my opinion.
Yeah, you have to use video. If you look at the Stanford group and David Camarillo's lab, who did X2 and some of their mouth guards, I mean, it was very meticulous, and that's what we do in the league. Is you have to match everything to video. What are you seeing, and match a lot of different parameters there. And on the NFL side, I can't speak for the other ones. A lot of these biomechanists are from the automotive, basically crash test industry out of Virginia Tech. And so they're really good at looking at sensor data. But again, what you see in the laboratory and what you see out in the field in real life is very difficult. So I think we'll get some useful data, but I'm not going to make any clinical decisions based on it.
Yeah, I would agree.
Yeah.
Gary, tell us quick, what's better, a hockey helmet or a traditional helmet?
Thanks.
Sorry,
that's okay. Yeah, no, we've looked at that, and it's really interesting. And Stan, you were part of the research on that. You probably better answer it than I have. But we've looked at that a lot, and it's interesting. It looks like they're both perform very well, actually. When players, and I didn't mention that research study we did, but when players are in before they come to the major leagues, they tend to use the hockey style helmet. Once they get to the major leagues and the minors, they kind of switch over to the other one. And so when we looked at it, we didn't really see a big difference in concussions, whether they were wearing it, which one they were wearing. A lot of it has to do with comfort as to which one they feel more comfortable wearing and which one they can see better. They both probably do a good job. We didn't see a major difference, but probably the most interesting thing in our study when we did Stan actually led a study of I think almost every catcher in almost all the organizations. And we found that most of the players who wore the hockey helmet felt it was safer, but a significant portion of those who were traditional mask wearers felt that the hockey one was safer, yet they wore the other one. So, we've done, I know Stan, you've done some biomechanical studies on that, and I think they all work fairly well. And I don't think we see a big difference at this point, but you've looked at this probably more than I have.
Well, a little bit, and one of the things that we've looked at, and this is why concussions is so tough, is that it's not necessarily the impact that causes the concussion. It's the angular acceleration that Dr. Batten talked about. And we found that when people got hit in the forehead or right between the eyes or in the chin, we saw more of those type of concussions simply because you got that contra coup type movement. And it wasn't necessarily how fast the fastball hit the mask or how it ricocheted off. It was about where it hit on the mask. And there's been a really good article on umpires that has shown some of that. So it is interesting that you see these guys, as everyone's talked about, the big hit, and the guy gets up and walks away and he has no concussion. Yet it looked like he should have had a concussion. And I think this rotational is what causes a lot of the concussions to the NFL and probably to hockey too. Hitting the ice or hitting the field and getting that motion as he hits the field may not be so much the impact, but the rotation.
Stan,
Absolutely.
I'll say one thing. I totally agree with that. And this isn't based on tons of data, but just being fortunate at Cal with all the different sports. If you ask me what sports probably had the worst concussions in terms of how symptomatic they were, how long did they last, recurrence, it was water polo.
Yeah.
And if you looked at sort of their mechanism of injury, is a lot of elbows to the side, there's a lot of rotational forces, which differs from football, where a vast majority are just, helmet to helmet, forehead to forehead, or occiput to turf. And, obviously you could see some significant injuries, but time and time again, when I saw injuries in rugby and water polo and soccer with those rotational motions, they tend to just be, I don't want to say worse, but just more symptomatic and more prolonged.
Yeah, I would agree. I take care of water polo at Pepperdine also. And yeah, we don't see a lot of them, but when you do,
Exactly.
they do tend to linger. And I think that the mechanism you're describing is exactly right, where you get a rotational aspect. And again, gets back to what you were asking about the sensors. The sensors are very good at linear acceleration. They're not as good at angular. And I think that's where we see some of the tearing of these bridging veins and things like that can cause these long-term effects. I agree with you, Casey.
Nancy?
All right. Has anyone started to incorporate subsymptomatic exercise with athletes who sustained a concussion prior to the return to play protocols?
Kevin, why don't you take that?
Yeah, sure. So what I think the question is do we start submax activity prior to the complete resolution of symptoms? That's the question I'm going to answer. So the answer to that question is yes, absolutely. We want the person to start to feel better, of course. But I think what we find is that we work with, very young, very healthy people, not zero comorbidities, but very few. And they get great sleep and they have great resources and great health and great food and great water and things like that. So, so they're really set up for success in that sense. And so we absolutely let their symptom scores come down, but I think you're going to be waiting a really long time if you wait until they get to zero. And so we let them plateau. I don't have a firm number where on the SCAT it has to get to this, but it's a low number, but it absolutely is not zero before we start activity. And activity is just stepwise. And that's kind of what we've all mentioned with regard to our different protocols, which is the word that I don't like. But, the point is that it's just common sense and it's stepwise and it's just very, very incremental. And so for us, our goal is always to not go backwards. So if we can do the same thing today that we did yesterday, that's cool. I would just prefer not to do less today than we did yesterday. But that might start with walking on the treadmill for 10 minutes. And as they BS with their friends, again, for us, our players aren't in an environment where they're also being interacted with at school or on group projects and things like that. So our environment is, for many people, especially if they're not married or they have a spouse who's not with them, the only interaction they get is when they're at the rink. So I want to get you to the rink as much as I can, and I want to give you a reason to come there. So it might be a spa day to start, where it's just, a hot tub and a steam and some ART and you're gone. But pretty quickly, we start to get them moving, absolutely. And we just try and make it very, very incremental, because I think that's really adjunctive, and that's really kind of props them and makes them feel better. Oh, I did more today than I did yesterday. And from a psychosocial perspective, we focus on that. Hey, good job, Nancy. You did more today than you did yesterday. That's great. Let's talk about what we're going to do tomorrow. So we're always looking forward, and we always start low, and then we just kind of build on that each time.
Initially, and return to play protocols, you'd increase their heart rate. You put them on a bike and you'd watch their increase in heart rate and if they had symptoms. But doesn't it have a little bit more to vestibular situations as a mechanism to start doing more and more activities? What do you guys think about the vestibular side of all that? Anybody? Anybody in the audience? But,
Well, here, I'll answer. So to go back, I very much echoes what Kevin said. The answer to doing early activation and exercise, not only does it make people feel better, it's based on good science. There's quite a bit of good, even animal and human data that shows people recover faster and completely when you get them moving and don't do the the quote unquote cocoon therapy, especially in younger people. In terms of the vestibular and ocular type exercises, this all goes back to, again, all the stuff that I forgot to say, Kevin said, so thank you. Concussion is very much treatable. We are not helpless against this injury where we just sit back and watch and hope they get better. You can intervene, and exercise is one thing, managing some of the psychiatric and depression and anxiety issues by involving them in appropriate activities. All of that's very important. And then I can't tell you how many people I see in my office who come in for quote unquote post-concussion syndrome. And, they're not getting a good physical exam. They're not looking at the cervical spine, which Kevin hit on. They're not looking at the vestibular ocular system, some very basic screening tests. And a lot of times you will find that people have these abnormalities that aren't necessarily manifestations of brain damage or dysfunctional neurons anymore. And they are easily, and many times easily, rehabbed. Even putting these people on a few basic exercises, sometimes in days and easily within weeks, I've seen some people go from becoming very symptomatic to very normal. We see this all the time in people who have who can't take a hit, and they I hear players that say, every time I get hit, I get the cobwebs, or I get a little dizzy, or my vision's a little blurry. If you really look and do the exam, you can often find a reason for that. And I've been pretty successful in working with the good therapists and getting these people asymptomatic. And so I've seen people who were recommended to retire because they said they had, brain problems and they shouldn't play contact sport. And they did 6 weeks of therapy and they were fine. So that's probably more info than you wanted, but the answer is yes to exercise, and big yes to vestibular, ocular, and cervical spine.
Nancy, how about one more from the audience?
Yeah, kind of along those lines. Have any of the leagues looked into utilizing a program to monitor how an athlete's sleeping, which is essential to recovering from not only concussion, but any injury?
So that's a hot button topic. I imagine I'll speak for the NHL, obviously, but that's a hot topic. And now you're starting to talk about, we get into this whole collective bargaining issue, right? Because now it's the business side of sports. And so and it's the whole, measurables and wearables. And so how much do the players want to give up? And so there's tons and tons of stuff out there. There's the ring, and apparently if you wear the ring, they can tell you if you have COVID like 3 days earlier, which is pretty impressive. But there's Whoop Band, and there's all sorts of really, really cool technology, really sexy technology with apps and all this stuff. The answer from the NHL is no, that's not on the table. It is absolutely not something. I mean, I guess everything's up for discussion. We'll end up with a CBA here in the next couple of years, but no, it is not on the table where the league is going to mandate anything like that. The Players Association has counseled their players to wear and choose whatever they want. I know this was an issue in the NBA as well. A lot of our players, we can provide you something. If you want to use it, great. We can give you some information. This is the Whoop. This is what I think it does. This is the Oura Ring. This is what it does. If players want to buy them on their own, great. If they want to ask us to help them interpret data, we're happy to do that too. So kind of the long answer to a simple question for the NHL is no, that's not being discussed at the league level. But absolutely teams, do have products that they recommend and will help their players support, and absolutely can use that data for a good. It's not Big Brother. Like, you can actually use that data for good. It's not all for evil, but it does become, an issue on the business side of sports that I think is where it gets kind of stuck.
Yeah, I would agree with Kevin. I mean, we have at the major league level, players can use it, but they have to. It's voluntary. They can't. They don't have to do it. The minor league level teams are using it, and I agree. I usually we're not always on the same side as the Players Association, but I can see the players' concern about this and this being used as contract. Like, for example, if you had a player who had a contract incentive that they pitched 200 innings and they're getting close, and all of a sudden they say, oh, you're redlining, and we're going to take, we're not going to play you. I think there would be concern from the players. But I think the teams that have used it successfully have really sold their players on it and showed it how it can actually help their career, and it can assist them in terms of staying healthy and reducing injuries. So I think that's the way to sell it to the players. But there are unfortunately business aspects that are part of that. But in terms of sleep is a big thing. We've looked at that with baseball in terms of the travel, although this year it's going to be interesting because there's not as much travel this year with a shorter season. So, we'll see. But, it's not like exactly that if the players had more time that they would stay in their beds and get more sleep. I think they would still use that extra time for, other things. So I think it is a really important thing. I think sleep contributes to a lot of these injuries and fatigue. So I think some of these things are certainly helpful.
Well, listen, we're out of time, but I do want to say one thing. In every one of your presentations, no matter what the topic was or anything else, players' unions came into play. And I think the general public doesn't quite understand that the players' union is, especially in Major League Baseball, NFL and NHL may be different, but there is a collaboration, but sometimes there's a lack of communication between the two in regards to a lot of this stuff. So that's a whole nother subject, which would be interesting, the business side and the use of wearables and everything else in regards to that. But listen, thank you very, very much. This has been very, very good. I just can't thank you guys enough for the quality of the presentations and taking your time and coming out and doing this. Thank you very much.
Thanks, Stan. Appreciate
Thanks,
it.
Stan.
For having us.
Thanks, guys.
All right, guys, to the audience, we're putting a poll up now on the survey to be able to get your CEUs. So make sure you please do that. We're going to leave the presentation on so you can go ahead and do that, but you will get another one in the email tomorrow in 24 hours. So you do that. Please do it. We can't give your CEUs if you don't fill out that survey. So thank you very much and good night.